My goal was to kind of do this every Thursday evening, 8 o'clock Central. Then it went to every other. And now it's been about 6-7 weeks. And I just basically didn't realize how tired I was after going 2 years of hard, just with my PhD studies at William Carey University, which wrapped up successfully in August. And so, but, I was exhausted. I was tired. And you know what? I think that for many of us as educators, we're just in that adrenaline mode and fight and flight for not only for hours, but for days, weeks, months. And now it's been almost a year. And, when you kind of come out of that, you really realize just how much of a toll it takes. And so, you know what? I hope that all of you are doing well. I'd love to get a shout out, see where you're from. Here in Minnesota, where I live, we've had 5 inches of snow about 10 days ago. It's still with us. We're going to have a snowy Halloween. And I know there's been some crazy weather across the country. So let me know who's out there tonight, where you're from. And it's exciting to have you with us here tonight. And the goal of this live stream, it's really about educators. It's really about you and supporting your needs and providing kind of a fun, informal place to share strategies. And what I've done with that, as I looked at taking some time off, I realized that what I wanted to do is to give other educators a platform. KeithRN has never been about Keith. It's been about transforming and strengthening how we teach nursing so our students graduate practice ready and we bridge the academic practice gap. And so even though I've developed a lot of strategies from Pat Benner's work, from educating nurses, a call for radical transformation that I highly recommend, that is still a must read for any nurse educator. I really want to give other educators a platform and an opportunity to share what they're doing to strengthen and transform nursing education with strategies and tools, and maybe how they're adapting some of the resources and tools that I've developed. And when I developed my Facebook group 2 years ago called Teachers Transforming Nursing Education, and that's a resource that I really want to encourage you all to take a look at. And recognize that this, put on the screen here, not all of you are Facebook people. I'm not a Facebook person, but I'll tell you, when I began my PhD studies 2 years ago, I wanted to stay connected to nurse educators and wasn't going to blog as much and everything else. And I just wanted a chance to connect differently. And this group has grown from 0 to 6,500 nurse educators from around the country. And I'm so proud of this caring, supportive community that if you're not a part of it, you know what, go after we're done today in the next 40 minutes or so, go to Facebook, sign up. In essence, it's a closed group. I don't want students in, so you got to answer some questions, nothing too personal. But you know what, this is a community you can ask any question and get immediate, literally within an hour, responses. And so I just kind of, as I've had dialogue with other educators, I just have had a chance to connect, and I'm inviting other educators. I'll tell you who I've got with me tonight in just a moment. So as we look at, with tonight, my platform has been, with KeithRN has been since 2012, developed a lot of tools and resources based on Pat Benner and her co-authors from Educating Nurses, and really have opportunity to have a lot of tools that can strengthen how nursing is taught. And I just want to kind of have a venue to see what other educators are doing. And who I have with me tonight is Denice Klassen. And Denice is a clinical coordinator for Wichita State University Technical Practical Nursing Program in Kansas, and has been teaching for 19 years, and in a current role the past 3 years, which involves being responsible for curriculum development for clinical courses, securing clinical sites, and placing students into their clinical rotations. She also works closely with the Director of Simulation Education and provides those simulation opportunities for students, I think doing both high and low fidelity simulation. And so I want you to warmly welcome Denice. I'm going to bring her into the live stream. Denice, are you there?
I am. Good evening.
Awesome. Hey, it's such a pleasure to have you with us tonight. And, we connected, Denice, was it about 3 years ago in 2017?
That was yes, it was.
And so I was speaking at a state conference in Kansas for nurse educators, and it was a full day workshop, actually a day and a half. And I talked about a lot of things about how to transform the classroom, the clinical, as well as infobesity and TMI. And I'm just kind of curious, just to get started, when we connected at that conference, there was a lot of information. I hope it wasn't too much, but what were your takeaways? That were some things that you took from that, a lot of information that you were able to implement, that you could kind of encourage other educators with?
Well, what we did, you're right. I think a lot of times our students have difficulty trying to connect what they're learning in their didactic courses with what's actually going on in clinical. And so after that conference, we came back and we made a very conscious effort of making sure that when we're doing things in clinicals, with the assignments that they were to do in clinicals, was aligning with the content that they were getting in their classwork, so that they could start tying some of that together. Infobesity, we hadn't heard of that term until that conference. And so we actually, as a faculty, started sitting down and saying, okay, where is it that we have too much? And started weeding out the need to know versus the nice to know.
And that's a common struggle, Denice. Educators say, it's all important. Mm-hmm. How do you begin to kind of, put that on a diet? So I'm kind of curious, what were some of the lenses? We all have glasses as we get older. I got cheaters. What were the lenses that you looked at as you took away some of the principles I shared? But what did you do to make that practical?
What we did was we took the NCSPN NCLEX PN test plan. We started looking at that. We started looking at what our program outcomes and our curriculum outcomes were that were written by our State Board of Nursing, and started saying, what can we take out? What is it that they really need to know? What's the basis that we can build other things on later? And that's kind of how we started to do it. Started with that.
Excellent. And so it's kind of like a journey of 1,000 miles. You took some first steps and you haven't looked back, I hope. Nope. You haven't kind of you've burned the ships and you're kind of just moving forward, I hope. Is that correct?
That's correct. When I first took over the curriculum for the clinicals, it was nothing for us to have over 1,000 points in a clinical, in a clinical course. And it's like, why? I mean, are we making them do things because it has value to it, or is it because we're trying to give them something to do to turn in? And we don't have that many assignments anymore, because we want them to get in there with the nurses. We want them to work and then be able to come back and reflect on what they've learned, and then try to tie that back to what they're doing in the classroom.
Okay, excellent. And, it's kind of like, since I presented that content 3 years ago, and some of the tools, strategies, resources, things have changed dramatically in the last 9 months since COVID hit in early of 2020. And so with the challenges, I'm just kind of curious, with your program, Denice, what are some of the challenges that you've been facing, and how have you been able to kind of just, whether it be with anything that KeithRN's developed, or just other strategies, how have you been able to kind of overcome them? I think we're always open and wanting to say, what are they doing that I can learn from? So I'd love to kind of get your thoughts on that.
Well, some of the things that we did when COVID first hit, just like everybody else, we shut everything down and we suspended clinicals and all sorts of things. And so we came back this summer, started opening up. Megan Bear is our director of simulation here at the college, and she worked really hard with making sure that we had the appropriately leveled simulations for our PN students, so that they could have those experiences that they weren't getting in clinicals. And we were able to beta test a whole bunch of stuff as to what worked, what didn't. But what we've done this fall is we admitted a full cohort. And so we've kind of split our classes. We're doing what I call a faux hybrid, where we have half the class on Zoom. one day and the other class, and the other half is in class, and then we flip-flop those things. I think as for a technical college in a large city that we have here in Wichita, we have students that can't even afford internet. And here we are trying to use Zoom and those kinds of things. So those are some of the things that we have had to deal with just on our end. But I think our students are doing well. I think our students are adapting. And I know that the faculty will do just whatever we can to make sure that they have the tools that are needed to be successful. And one of the things that we did do was for this fall, for clinicals, we're using a lot of the case studies for our students to kind of help them with that critical thinking, even though they don't have the hands-on with patients other than our mannequins.
So are you doing that in the classroom, Denice, or in the clinical setting?
We use the case studies both in the didactic classroom as well as in clinicals.
Okay, so why don't you tell us a little bit about with the classroom? So let's start with the classroom, especially now that we're kind of doing Zoom more than we'd like to, and all that looks like. You know, your program has a departmental membership to the all-inclusive tool, so you have access to over 100 case studies, different levels, and kind of all the things that have been developed over the years. So I'd really like to know just kind of how you're using them, starting with the classroom, and what level of case study are you finding most helpful, and kind of then what students' response and kind of the big picture is looking like.
Well, since this is a practical nursing program, what we do is we tend to we use more of the first year, that first or second semester level of case studies, and we start out with the smaller ones, like maybe the rapid reasoning or the skinny reasoning is what we do to kind of get them used to it, and then we build on that. So we use the case studies. The other thing that we did was we took the medication list, and we actually sat down as a faculty, looked through that list and said, okay, where are we going to teach this content? And we divvied up that list of 75 drugs that are just those need to know drugs that they absolutely have to know. And we've pulled that, and it is throughout the program. They get those drugs in didactic and clinical, so they get it all the way through.
So what you're sharing there, Denice, is kind of one of the strategies that I shared at the conference, which was in essence identifying in your program or in your community, what are those most commonly used medications that are used, and identify at least 10 to 15 for every, every didactic of clinical, whether it be fundamentals, basic, advanced, your specialties. What are those 10 to 15 that I kind of call need to know medications? And so what you've done is that you did the hard work to identify those 10 to 15 for every level of clinical, identified them, and then you integrated them intentionally into the case studies as kind of like an additional supplemental pharmacology. I'd love to know how you kind of put those two together. That's great, by the way. I've never heard of that specifically, but it's just bringing clinical into the classroom, which is really what Benner says we need to do to transform nursing education, is to bring clinical and classroom together, integrating it, not in separate orbits like it rarely intersects. So I'd love to just expound upon that just a little bit. I just love that.
So what we did, we'll just use one section. For an example, in Nursing Care of Adults 1, they have at the same time, they have Nursing Care of Adults 1 clinical. So when I built the modules, what we did was, if they're studying cardiac, all right, the cardiac system in didactic, what I did was during that time, they actually are focused on the cardiac system. We're doing focused care plans. We're doing focused assessments. We are trying to compare between what's normal and what's abnormal for patients who have cardiac issues. And then we get into the drugs, and the drugs are both in didactic as well as clinical. So hopefully they can start seeing some of those things come together, and we can say, so what are you studying in class right now? And they'll tell us, okay, so how does this apply to clinical? And just making sure that even the language that we use and the terms that we use within clinical match up with what they're learning in didactic class. So I've sat down with their textbooks and say, okay, if this is what the textbook is saying is a focused assessment, this is what we're doing and how that particular assignment is written, so that there is no confusion, because sometimes there's, we have terms for different things, but you want that language consistent, especially in that first year or in that first semester when they're trying to learn so much. So if you can keep it consistent across the board, I think there's a better chance that they're going to understand it a little bit better.
And what is the one thing, Denice, if there's one thing that you want your students to know about pharmacology? So of those 75 meds, of those 10 to 15 for every level of didactic, and how you integrated like those cardiac medications, what is the one thing that you really want your students to know deeply? And did your students have a struggle with that one thing? Because I talked about that. And you remember what it was?
No.
Mechanism of action.
And there you go. That's right.
If they understand the mechanism of action of any drug, but specifically the most commonly used drugs, they will understand and know what the most common side effects are, the nursing implications, and what assessments need to be done before they administer, because they know how it acts on the body. So how are you doing with that? And how are your students doing with that understanding of mechanism of action and applying pathophysiology?
We're starting to see some light bulbs go off. And so when it's really kind of fun to watch them be able to make that connection. And of course, we're teaching everything across the lifespan. And so does this drug work the same as in the elderly patient as it would in let's say somebody who's a little bit younger? And what are those types of things that we need to look at as far as, gender or age? Same drug, is it going to act differently? And if so, why? And if not, why? And so just starting to put on those, just having them start to look through that. And we even will say, okay, so here's the disease process. What drugs would you expect them to be on? And I love, like in the case studies where they have the list of medications, and it's like, okay, so now go back up to the health history and tell me what drugs are treating which one of their diagnoses that they have, just so that they start making those connections.
Yes, because those same connections, Denice, are what we want them to do in clinical.
Yes.
Where they can look at a patient's home medication list, look at their problem list of their past medical history, and begin to see how
together.
And that's beginning to put what Chris Tanner in her clinical judgment model talks about, pattern recognition.
Right.
You begin to see that data is not just abstract, but it has a relationship. It has a fit.
And when they do their assessments on the patients, they actually have to, when they do their med list, they actually have to go back and say, okay, so what is this treating? Look at their disease list. What is this treating? And then we actually have them go out and say, okay, so what labs would be associated with this? Just so that they start getting, like you said, the patterns, or understanding what they need to be looking for as the nurse.
Okay. I just got a question here from Misty, who just has a great question I wanted to throw out there because it kind of ties in with what we're talking about. She asked, how did you determine the needed medications to have in the program? So how did you, I gave you some practical strategies, but how did you develop those 10 to 15 medications for every didactic clinical that you then apply in the classroom? And then you'd have 75 or so at the end of the program. What criteria did you use, Denice, to identify those need-to-know medications?
What we did is we started with the list that is in the back of Think Like a Nurse of those medications that need to know. We started with that, and then we looked at those and said, okay, so is this applicable for an LPN? And then we started talking about, well, what kind of medications are we seeing our residents on in clinicals, and what are they seeing?
What's commonly used?
What's common used? Yes. And so that's kind of how we determined what drugs we were going to use.
Okay. And do you kind of go then and kind of go the path of like specific medications or classifications of drugs, like beta blockers, for example, versus a atenolol or metoprolol? How did you kind of split that baby to kind of, because once you know the classification, those principles of the mech of action are really going to be the same, just dosages will be different of different medications within that pharm class. So how did you kind of do that dance?
That in the state of Kansas, our PN program, our curriculum is very precise or very prescriptive. Let me say that from the State Board of Nursing. And so pharmacology actually is no longer like a traditional pharmacology course like we see it. And it's actually been embedded into the didactic courses. And so so it's a little bit different. So what we do is we look at classifications of drugs, and then we do one or two exemplars for that particular class that, again, what are they going to see when they're out there, and try to stay away from some of the rarer things. Like, for an example, a PN's not going to administer like one of the clot busters. They're just not going to do that. They need to know that they're out there. So why have them memorize all that stuff? It's that need to know versus nice to know. This is a nice to know thing. You might see this is what they are, but they're within their scope of practice. They're not going to be administering those.
No, that's a great point. And so in answer to even Misty's question, when you look at how do you identify those medications, that's really a good filter of even putting your pharmacology content on a diet and your general classroom content. What does that need to know versus nice to know? And I mean, sometimes it's very clear, sometimes it's a little shady, but that's where we can use the NCSBN test plan, our outcomes, our what's most common in our geographic area, what medications are being used. So the curriculum needs to be tailored to our where we're located, not just a general NCSBN NCLEX plan. It's like, what are my students going to see? What medications are most common in our practice settings? So yeah, that's great feedback. And I just wanted to highlight, Megan says, the Think Like a Nurse template. This is actually the student textbook that Denice is referring to. This is a student textbook, Think Like a Nurse, that is in its second edition, and we'll talk about that a little bit later. But there's a template under pharmacology content you need to know in chapter 5, I do believe, that has I kind of identified those top 50 plus that I see here geographically in the Midwest, where I practice here in Minneapolis in this section of town. But again, I think they're pretty universal and pretty standard. So in the classroom, you're using the case studies and integrating pharmacology, kind of, adding to the case studies. And I think that's a really important point, Denice, is that, even though the case studies, like the skinny reasoning, they're short, concise, they've got just 4 pages. You can do this in about 30 plus minutes. You can add to it and you can subtract from them based on what your learning needs, because a practical program is going to be different than an RN at some content. But do you find that most of the questions are relevant and the scope of practice of most of the content for a practical or vocational program?
It is, and we even if we get into some, like I said, we try to stay with the ones that are for that first year nursing student versus the second year nursing student. And even if we come across something that may be outside of their scope of practice, for them, that is a great opportunity to talk about what's within your scope of practice. What is your responsibility to know this, and what are you going to do? You may not be able right now in the state of Kansas, you may not be able to administer medications without an additional IV course, but you are still responsible for checking that IV site. You're still responsible for making sure that the drip rate is correct. So they have all of those other responsibilities. And if something's wrong, what are you going to do? And so it's a great opportunity to do that and to kind of get them thinking a little bit differently with things.
Excellent. I'm kind of curious, Denice, what is, you have the departmental membership. So all faculty have access to the same tools and case studies that can, again, bring context to the content. And that's another transformational paradigm that Dr. Benner talked about in educating nurses, that we need to bring context or contextualize the content to the bedside of patient care. But I'm really curious, how has the buy-in been from faculty? Because as you know, when I talk to programs, it's kind of all over the board. Now, you don't have to say too much, but I'm just kind of curious, are your faculty, after 3 years of using the cases and the resources inside the membership, are they finding is the buy-in coming because they're seeing the value? I'm just kind of curious what that journey has looked like, because it looks differently in every program. But how did that look like for your program, and where you are today compared to 3 years ago with really faculty making change and implementing it?
One of our faculty was really, she really pushed for adopting the Think Like a Nurse textbook. And we actually started in one of our prereq courses called Transitions to Nursing. And that's their first introduction to nursing, is where we keep that. And faculty, I think, have found the case studies to be easy to use. The students, I think, like them. We break them up into little, pieces. We might do the first couple of questions on a case study and have them work in groups. And then we come back and then we talk about, so why? Is this correct? Why is this correct? What, like when you pick out the priority problem, just don't pick it out. Tell me why. What was your line of thinking? So that we can kind of adjust some of that and address some of the different issues that they come up with that. I don't think that there isn't a I don't think that there isn't a didactic course that doesn't use at least one KeithRN case study, or at least one. And again, we sat down with the book and we said, okay, what's appropriate? Where are we going to put this? Where's this content going to be within the program? So they use the book consistently throughout the program. It's not just a one class and you're done with it.
Yeah. Is there any specific content that you have found most helpful or valuable from the student textbook, Denice?
I like the tools in the back that they use. So I,
Are you referring like to the lab planning?
Right, the lab planning sheet. We also, Foundations is where they first, Foundations in Nursing is where they start getting their first introduction into lab work. So we use some of the lab work cheat sheet that's back there just to kind of get them to think about what it is that they need to look at, what's important when we start, what does a trend mean? Yes. When we start talking about laboratory trends, yes. What does that mean? Yes. And what does it mean for the patient? So we even start out, even in first semester, first few weeks, we're into getting in, because we have them for such a short amount of time.
Yeah. And that trending of all clinical data, whether it be lab values, vital signs, assessment, that's a key construct of clinical reasoning that leads to correct judgment. And so that trending, and you're just kind of making it practical, it sounds like, and making it just, kind of like a skill. And even asking the why question, Denice, do you not do that in clinical? Yes. In addition to the classroom?
Yes, and clinical's why. Sometimes I feel like I'm a toddler. Why? Why?
But you know what? That's the rationale. And when our students understand the why, and when you're asking the why in the safety of the classroom, what I really love of what you're doing is that you're really part of the change. You're bringing that clinical context into the classroom and helping students to see the value of these why and the deeper application of learning. So I just, it really doesn't have to be so difficult, but I think, overcoming and resisting change, was there a struggle, and did you, was that able to be overcome over time with some faculty? Because that's really, when I talk to educators, there are some that have seen the light, but then there are others that just want to dig in. So it's like, I'm just kind of curious, do you have any words of wisdom or pearls that you learned, as you look back, that just slowly was able to move the chain forward, and you still were able to implement the needed change?
I will say that we have had some changes in our faculty in the last year or two. And I honestly, from the bottom of my heart, I have never worked with a better group of women in my entire life. They want our students to be the best nurses when they graduate. They have a heart for our students, and when we start, we had, we haven't had issues, but let's say our NCLEX first time pass rates not where we want it or wanted it. Let's put it this way. So when we started implementing some of the principles out of the KeithRN textbook, as well as the case studies, and we started to see the increase in our NCLEX go up. And I think that kind of helped with, we really need to do these. These are really good. The students enjoy doing them. And I think for some of our faculty, it was just, okay, here, let's do this one case study, do it and see what you think, and we can go from there.
So, a lot of faculty say that students resist active learning. They don't like to work any harder than they have to. And I'm kind of curious, How did you get your, it sounds like your students are buying in, Denice. I'm kind of curious, just why do you, what do you attribute that to? And was there kind of a curve you had to overcome with students as well?
At
If you're
first,
brutally honest.
at first the students hate them. And it's like, why are we doing this? But I think when they start seeing, and as an educator, it is fun to start seeing those light bulbs go off and have them say, I never thought about it that way, or, well, that makes sense. So I think as they get used to the case studies and they get used to how they're outlined and what they know they're going to have to do with them, I think it's better. And again, we use a lot of these in class. We don't assign them as homework for them. I think that was part of the buy-in. You've got enough homework as it is. We're going to do these at clinical. So, I don't want you going out and looking these answers up. Just bring them with you to clinical, and we'll work on these a little bit at a time. And I think that really helped with some of the buy-in from the students.
So did you kind of do some of the skinny reasoning, the shorter version in the post-conference, or how did you integrate these in the clinical setting?
You can start out in nursing care of adults one clinical, what I did especially with our evening group, because we all know evening clinicals in a nursing home, they're all in bed by 8. And if you've got clinicals till 10, you're struggling sometimes to figure out. So we would start out just like with the acronyms. I pulled that out one time and said, here, let's do the acronyms. Yep, and it was hysterical. It was hysterical with what they came up with what the abbreviations meant, And I said, I hope you're not mad at me, but these are funny. And then we pulled out a larger one and said, okay, we're just going to do these 2 sections tonight, and tomorrow night we'll do the next 2 sections. And you put them into groups, they work together. And so that's kind of how we've done it in clinicals that way.
So kind of able to productively use the downtime.
Yes.
That inherently is present. If you have a day clinical, as you know, a lot of students typically are busy, but some students just don't get the best patient, and it's not as busy as you expected. And they're sitting there and they're just maybe, having the short case study or other resources that are inside the membership, like the lab planning that helps make lab, kind of making a plan of care around a bad lab, are some meaningful activities that you can redeem the time. Has that been kind of your experience?
Yes. I mean, and like you said, there is downtime. And I think we tend to do our clinicals a little bit different than maybe some of the RM programs. We don't assign them patients. We assign them to nurses. And so they're expected to work with that nurse and work with that nurse's caseload for the day. And it may be that, it may be that they have 4 or 5 patients. It may be, depending on where they're at. If they're at the VA, they may have 1 or 2 patients in ICU, or they may be hanging out with the ED nurses for that particular day. Okay. So that's what we tend to do, more than just specific, this is your 1 or 2 patients that you're going to have today.
Got it. It's gone so quickly, Denice. We're going to wrap it up here in just a few minutes, and then we're going to have some questions. But I do want to close with this thought as far as I'd love to know, what are some of your pearls that you've acquired as an educator? You've been an educator for 19 years.
Yes.
And so that's 2 decades. And there's a lot of educators that are listening to this live stream that are novices. They're brand new, less than 3 years, and they're still kind of learning the ropes, and it's not easy, especially in this pandemic. And so I'm just kind of curious, I don't see any gray hair. I've got a salt and pepper beard. I got some gray hairs in the beard. So there's a little bit of wisdom in Keith, but I would love to know, after 2 decades, what has been some things that you could share to kind of encourage educators in their journey, especially those that may be new.
Well, they're not all going to like you.
Students, you mean, or the faculty?
Yeah, students are not always going to like you. But you know what I have found through the years is that you try to build relationships with them. There's a reason why we went into nursing, is because we're people person. We're people, we're person people. But anyway, we like to be around people. We like to converse. We like to talk with people. And so building those relationships with your students, because we have a demographic of students that really have some life challenges. And by building those relationships, they feel comfortable coming in and saying, I'm having this issue. I don't know what to do. and so that we can take care of them so that they can be successful within the program and start to build a better life for themselves and for their families.
Yeah, I can tell you, Denice, that's a powerful principle because, one of the things that programs struggle with is attrition. Students drop off after, we don't retain our students, as high as 30-40% attrition in some programs. Did you know that men in nursing, your male students, by the way, are one of the highest at-risk demographics according to the nursing literature? But the strategy that you've just explained of developing an authentic and an appropriate relationship with your students to show that you do care, and again, having just like a nurse-patient relationship has its boundaries. When you have healthy student-educator boundaries, it sounds like that's really something that can really be a value. It can be a win-win, can it not?
Yes, it can.
And just like parents, you're not always going to be liked, but you're going to be, I think at the end of the program, you'll be that educator. They're going to write back and say, thank you, for that tough love or whatever it was that you pushed them for excellence. Any other thoughts or pearls before anything else you'd like to share that you may have made note of?
Oh, loving the COVID case studies, by the way. So thank you. I think it's very appropriate. Yes. And we're even using them in the PN program, at least the first two.
Excellent. And the COVID-19 is now a 5-part series. Part 1 is on KeithRN. In fact, I want you to all know, I would love all of you, if you haven't gotten it, I got a free case study of skinny reasoning, COVID Part 1 on KeithRN.com. Just go to KeithRN.com. It's at the very top of the heading. Download it. There's a link. There's a sign up. And bottom line is use it. I've got Part 2 is a change of status. They go into respiratory failure. So they look good in Part 1. Now they start to slide on med surge. Part 3 is going into ARDS and respiratory failure and sepsis in Part 3. And now it's ICU. So now it's an advanced med surge. Mm-hmm. So it goes from basic, med surge, advanced med surge, ICU in Part 3. And then Part 4 is he does survive, but now it's community and public health.
That's right.
And those priorities that are contextualized. And then Part 5 are the clinical dilemmas that COVID has raised, like lack of gear, lack of equipment for family, or the inability of the wife to be with the husband who is dying or is critical. And how do you navigate that? So really got some very practical dilemmas from the real world crucible of practice. So thanks for mentioning that, Denice. And I'm going to just we're going to come back to you in just a couple minutes. So don't go away. Okay.
All right.
We're going to have some questions with Denice here in just a moment, but I just wanted to just kind of close and let you know that if you're looking for, again, that free COVID case study, go to KeithRN, download that. I've got 25 to 30 other topics that you can also purchase on KeithRN, as well as a blog with other resources and handouts for you. I also want to let you know that the student textbook, Think Like a Nurse, that I've written for students, I'm in the process of revising it for the 3rd edition, but this is really a unique text that Denise's program has adopted that really provides a practice-based perspective of essential content. And if you want to purchase a paper textbook, you can use the coupon code KeithRN20 by going to the website. I also am going to be really generous tonight. If you email me at keith@keithrn.com, if you're interested in just a faculty preview copy as an ebook, I'll be glad to send that to you with no obligation. But if you are interested to learn more about this student resource that has some tools, resources, and just practical strategies to help transition to practice, I'd love to get that into your hands. Finally, I just want to let you know that I do have a departmental membership called Think Like a Nurse that has over 110 case study topics. And so I've got almost 4 times as many resources inside the all-inclusive membership, which is kind of like a buffet, with additional handouts for clinical, teaching webinars with continuing education, taking my full-day workshop and breaking it up into 20 and 30-minute bite-sized pieces. And it can provide the faculty development as well as the tools. So I just want you to know that I've got resources that can really help strengthen and transform the way that we teach in nursing education. And That's the website, thinklikeanurse.co. It's not a .com yet, but it is co. Thinklikeanurse.co. Be sure to just kind of check out that landing page and learn more. And if you're a departmental membership, I can provide a discount for your program. So just let me know again. Email me if there's an interest. But I would just love to just kind of get Denice back in and say, you know what, with what Denice shared tonight, what was your big takeaway? You know, it's kind of like, just like with a good content presentation, you always want to ask your students, what did you take away? This is what I want you to take away, but this is what you took away. What did you take away that you can apply? And what questions do you have to strengthen student learning or faculty teaching that Denice shared tonight? So I'm going to look in the chat. And so I just want to get some feedback. And since we're not live in the sense that we can have I can't hear you verbally, we've got to kind of put this all in the chat. And so I'm just going to kind of look back a little bit. And so if you have a question or a takeaway, I'd love to put it in there. And, you know, Megan said this, LPNs are wonderful public health advocates. Would you kind of agree, Denice, that LPNs are kind of like the Rodney Dangerfield of nursing? They just don't get enough respect.
That's true. And it really, as a BSNRN, I get really irritated when I have colleagues say that they're not nurses. Yes, they are. And they learn everything that first year that an RN student learns, and they don't have half of the prereqs that the RN students do. And so they're an amazing group of students that learn a lot. And when they come in and they care for the patients, that's stuff I can't teach. And so it's just really exciting to see them grow.
Yeah, no, that's good. And I think that what I've seen from practical nursing programs is that you really raise that bar of thinking that they are reasoning, and you know how they're taught to think and reason. I think what I've been impressed with practical educators is that they really want to raise that bar. They're not kind of just wanting glorified nursing assistants. They're pushing them at literally the RN level of thinking and reasoning and understanding. They just don't have that scope of practice by most boards of nursing. But the thinking, what I see from practical faculty, I am thoroughly impressed. So what I got from Misty, she says, put your classes on a diet. And, yes. I would like to maybe until I get another comment or two, I would like to know, what are some practical things, Denice, that you did to kind of, how did you teach the classroom, and how are you doing it now by Zoom? So in the sense of, are you doing like everything online with, and then all active learning with case studies and other activities? Or are you kind of doing a 20-minute need to know and then go into activities? So, and then what are you doing to kind of highlight what's most important with classroom content?
What we do is, of course, they all say they want lecture, right?
They want to be, it's called spoon feed me. It's called regressing, and we don't want to encourage regressing of student behaviors. They're adult learners.
What I like to do is I like to start out my classes. Okay, so this was your assigned reading, and I tend to run more of a flipped classroom. So here's your assignments. This is what I expect you to have at least looked at before you come to class. It's like, okay, so here's all the things that's in the things that are available to you. What questions do you have? What concepts did you not understand? And most of the time it's crickets, I will say. But then you start pulling out, okay, so tell me what this is. Just like the other day, I asked, what's the difference between pharmacokinetics and pharmacodynamics? And they looked at me as if I swore at them. But, so that's kind of how I start. And then I tend to look at what is it that I really want them to get out of a particular chapter. I may lecture for 10 or 15 minutes. And then it's okay. So now here's the activities that we're going to do to help you get back into the content. So we start putting some of this stuff together. And it's like, okay, so tell me what you're doing in clinicals. What do you guys learn? So how does this apply to what you're doing in the clinicals? And trying to do it that way. And we do tend to have them work in groups with each other. Sometimes we let them make their groups. Sometimes we put them into groups ourselves. And then we come back. And I always try to break it up. I never try to just do it for 30 or 40 minutes, but I try to break it up maybe just in little pieces of 10 or 15 minutes, maybe 20 if it's something lengthy that they need to do. And then, okay, let's come back out and let's talk about what you did and how you prioritized what you needed to do.
Excellent. And you know what you're doing, Denice, that's really an expert education is that you're asking questions. You're not, sometimes we just kind of tend to just give them just because of our, we just to fill up the time and we just give them content, but you're asking questions and then you're giving them, you're providing the opportunity, but then you're bringing in clinical realities and asking those questions. How does this relate to what you're seeing in clinical? And so those are some very simple, but they're powerful learning strategies that anybody listening to this can take away and kind of think about what are those questions that I could ask my students, because you can read minds as an educator by asking the right questions. We do it in clinical all the time. We need to kind of bring those questions we use in clinical into the classroom. And that why question you mentioned at the beginning, I think that's a go to the bank, why and what that looks like. Got some questions here from Megan. She asked, how has long-term care facilities not having students impacted your clinical experiences? And so did you have a season, Denice, where you didn't have the opportunities to go to the long-term care facilities? And what did you do in response to that?
Well, what we did was we went to strictly simulation, and we're talking high fidelity simulation. Again, I worked really closely with our director of simulation. And let me tell you, she worked really hard to make sure that they were leveled appropriately. And we're talking about, we are very fortunate to where we have 4 of the Lairdale nursing anns. And so we actually are taking NLN simulation content. We also use some of the work that was done by the South Dakota University. Again, leveling it appropriately for the LPN. And that's what they're doing. And so we're doing, full on pre-briefs. They come in, they do their simulation experience. They come back, we do full on post brief with the students. And a lot of the comments are, I learned more out of this one simulation than I have in XYZ. You can fill in the blanks with that. But they're liking it. And I think simulation education, and there's not a lot of research out there for the PN. So that's one of my things that I would like to do to see how it helps bridge those gaps for the PN students. But they're starting to make those connections, and simulation provides a safe place for them to make mistakes.
That's right. Just like the classroom when you're using a case study.
Yes.
Which is low fidelity simulation. You just don't have the skills lab.
Right. And so, we are fortunate to have the simulation hospital that we do. We're fortunate to have the mannequins that we do. We're very proud of the equipment that we have to train our students. And we're seeing results. The students are, I believe, we're starting to make those connections, and we're starting to see our NCLEX first time pass rates going back up where we would like them.
Good. That's excellent. Thank you for sharing. Just got one last comment, unless anything else comes through, is Mila just made the comment that when it comes to engaging with Zoom and video conferencing, I'll just put on the screen that using the chat often for student engagement, then using breakout rooms.
Yes.
What have you found, Denice, and how would you build upon that just from your experience as it relates to when you're doing the video or the virtual classrooms? What are some strategies that you've just found helpful to really rock it and engage students who just want to kind of just kind of like, be the wallflower?
There's always the wheel of death. We have a wheel where we can put the students' names in. If they're not being too interactive, we get it out. Okay, so you're going to answer the next question. But I love the breakout rooms. And again, we'll break that up, with the case studies. We'll say, okay, I'm going to put you into a room of 2 or 3, depending on how many students I have. And I want you to look at the first 2 questions on this page.
Yeah.
All right, write it down. They have they'll have the case studies ahead of time. The fillable PDFs are wonderful because I've created within our LMS. I've created drop boxes so that when they're done with that evening's clinical, they go ahead and they save it. They can put it in the drop box, and I have my documentation for the state board that says, yes, we're doing this. This is what we're doing. But by doing that in the breakout rooms, they can talk amongst themselves, and then we bring them back And you can jump into those breakout rooms, see how they're doing, see if they have any questions. Sometimes they'll have some questions that are really good questions. It's like, wow, okay, so you have a little bit of time to do that. Come back out, and then you can discuss it with the whole group. And I think sometimes they want to know what's going to happen in the end of the patient. It's almost like a story for them. So yeah, breakout rooms are fabulous. We use that. I use that with all of my classes that I teach.
No, excellent. That's excellent. And yeah, Jamie says that everyone's on the opportunity wheel in his program as well. So no hiding. And do you find that your students are getting just as much learning virtually when you do it this way, when you bring active learning, small group discussion? I mean, that's really what you do if you had them in front of you.
Mm-hmm.
You would do some of these same principles of breaking them up into small groups, active learning, whether it be case-based or some of the resources that I've developed or anything else that you've developed that brings clinical realities. In principle, isn't it the same? Are you seeing a drop off, or can we really have a similar bar of learning and feeling that your students are still getting it despite the virtual reality of classroom where it is in so many programs?
I think we can. It's not everybody's favorite. I can say that. And we did lose some students when COVID first hit last semester. We simply lost some students because they said, we are not online learners. I've taken classes, I'm not successful. And so they decided to go ahead and withdraw at that point until they knew we could have face-to-face classes again. And that, so it's not for everybody. You have to have some self-discipline in order to be successful in a truly online environment. So it's still hard. I don't, even though Zoom's a wonderful technology, I would rather see my students every day. I would rather see them face to face.
It's still a connection. It's still a connection that even, it's okay. But going to a conference, for example, that's virtual, it's okay. It's convenient.
Yeah.
It's not the same for nurse educators and all the, I've presented virtually. I've attended virtually. It's okay, but it's not quite the same. That connection of face-to-face, we're still meant to be connected. I don't think as human beings, it's still not ideal, but we're doing the best we can. And I'm just going to give a shout out to Jamie here. He has a wheel of opportunity that a link where you can do like the wheel of fortune, do the wheel of names and spin the wheel. I love that, Jamie. Thank you so much for sharing that.
The students hate it.
I know, but it keeps them accountable. And so that's so much, Denice, there was so much information you shared tonight. I just want to thank you. I know the educators that were listening got a lot of just practical information, and we all need this. And, my goal, I'm going to be back next week, next Thursday, with another educator that could be you. And what I want to just let you know is that if you would like to be considered, if you've done some innovative strategies, classroom, clinical, simulation, KeithRN, not KeithRN, you know what? Contact me. Keith@KeithRN.com by email. That's my email. I'd love to hear from you and give you a platform like Denice had tonight. So Denice, I want to thank you again. And just want to thank all of you as educators for checking this out, and look forward to supporting your needs and doing all that I can to best serve your needs to strengthen and transform nursing education. Thanks so much and have a great night.
Thanks, you.
Denice. Blessings to you. Take care.